So, as I am talking to you here today about what exactly a vascular surgeon does, I'm going to be drawing on my little Apple device here and trying to get some pictures to you guys so it all remains relevant. I think the first thing we should talk about is just basic idea about what a vascular surgeon does. Vascular surgery, first of all, surgery is a general class of medicine where we actually intervene by essentially making incisions, puncturing the skin, and essentially operating, doing some sort of procedure on a patient, which, according to my older professors, you actually always harm the patient in order to help them. And that means you actually need to literally cut something to actually fix it on the back end. The reality of that is that everything that we do causes some degree of pain and comes with some ultimate benefit, hopefully. Vascular surgery can be used to treat a wide range of um, heart and blood flow issues. There are a number of different things that come up within the body that that may require vascular surgery, such as aneurysms, which is a swelling in the blood vessel, and um, clots in the blood vessels, varicose veins in the blood vessels, um, blockages in the blood vessels, and essentially there's just a very wide swath of different diseases. The treatment options that we have available, treatments that we have available, we can give you usually as a vascular surgeon either an open operation where we make a big incision and actually cut something and open something up and actually fix it, sew it in the old-fashioned way, or we can do minimally invasive surgery, and those procedures are usually involving needles and wires and catheters. Now there is some parts of vascular surgery, and this is going to be a really exciting new part of vascular surgery, which kind of goes back to old school training. But I think in the future we will see more and more of it, and that's robotic surgery. So robotic surgery is sort of the minimal invasive way of operating if you were a general surgeon. If you're in the old days, you had to do a gallbladder, take the gallbladder out, etc. You do it with a big open incision, and many people across the world get their operations through a big open incision beneath the rib cage. Fast forward in time, they developed laparoscopic surgery where you're able to use instruments that are about the diameter of this pencil, insert them into the abdomen, and pull the gallbladder out. Fast forward in time past that, we now can have those instruments robotically controlled by fingers that have multiple ways of articulating, and this way we can more precisely, without any more finger tremor issues, dissect the gallbladder out and do the same essentially laparoscopic method. But in this case, what we're doing is removing it while using instruments that are being controlled and a little bit more stable. So a lot of surgeons are now moving towards this robotic technique of removing organs and doing surgeries and creating suture lines, etc. We are a little bit behind on that in vascular surgery, but I think it's just because really we're so far ahead when it comes to minimally invasive, putting wires in, catheters in, and doing stents. For the most part, we can fix many of the problems, in fact, almost all of the problems that we encounter these days relatively well with simply wires and catheters that travel through the blood vessels that have very little impact on the patient at the end of the case when we remove everything from the blood vessels. So these are the main important portions. So I think the next part of what we should talk about is, what does a vascular surgeon operate on? Well, there's three main blood vessels in the body. Imagine this is your heart, and your heart is pumping blood outward to the rest of the body, pumping it to the kidneys, the lower extremities, and all sorts, and your intestines. The blood flow is this direction and includes up to the brain and to the hands. Now, in these situations, what we find is that if the person, this is the arteries of the body, and as vascular surgeons, we operate on more or less almost all of these portions of the body. And I would say that I think there's some variability between what each of us individually feels comfortable doing, depending on where we trained. But I think for the most part, most of us would operate on the aorta as it leaves the heart, the neck vessels, the arm vessels, and that goes all the way down to just about the wrist. Some of us will even dive into this portion of the wrist, but I think most of us will treat all the way down at that far, at least surgically. Now, medically, prescribed medications, we treat all the way to the tips of your fingertips, your toes, everywhere. We're versed with all the medical treatments for the most part. But I think if you needed someone to operate on your fingertips, you would probably go to, or on the nerves in your hand, you would probably go to a hand surgeon who would be a plastic surgeon, or a orthopedic surgeon or general surgeon who went into hand fellowship afterwards. Similarly, we operate on the neck vessels, but we wouldn't really operate above the base of your skull. Very rarely do we end up in the actual brain operating. Some of us, again, are different, but I'm just talking bread and butter for the most part. If you go in to see a vascular surgeon, most of us stop at around the extracranial, the outside of the brain carotid artery. And we will do clean outs and we'll fix the veins up in this portion of the neck. We'll put catheters up here, but we don't go up higher into the brain. If you have to open the skull, you probably need a neurosurgeon. If you need open surgery, remember we talked about open versus minimal invasive. And if you wanted to go into the brain vessels minimally invasively, you need someone like a neurointerventional radiologist or an interventional neurologist of some sort. So you need someone in neurovascular radiologist. There's all these different terms, but you really need someone who is minimally invasively able to pass wires and catheters or treat things like strokes and aneurysms in the brain. And even some neurosurgeons nowadays are being trained. In fact, many neurosurgeons nowadays in my generation are being trained to do these wire-based procedures also. The beautiful thing about usually going with someone who has the word surgeon in their name is that they're not just an interventionist. So they can do the minimal invasive sometimes as well as the maximal invasive. And if the minimal invasive goes wrong, you can usually reflexively turn around and do the maximal invasive. And the other benefit is, as a surgeon, and only surgeons know this, but if you have the ability to either use a hammer or a saw, and you have two options available, you will pick the best option. Typically that comes to your mind. Whereas if you only have one tool in your tool belt, you will typically pick that tool. So I think we have a little bit of an advantage as the surgeons, and it comes along with additional training that we had to do after residency, but I think that's as much as I would say regarding the arteries. Now, if you wanted to do on the other side of the body, just to briefly summarize, you have the veins. Now, almost essentially for every single artery and vein, there becomes an opposite side. And the veins are much bigger capacitance vessels. You will have a big renal vein on the right, long renal vein over here. Here's your kidney. Kidney is a renal, right? And these veins are bringing blood back upward towards the heart. Now, when people have things like a blood clot, which sits in the pelvic veins or in the lower extremity veins, let's just say we're coming down here at your groin, and you have a clot sitting here somewhere stuck along because you had a long flight or a long trip on the road, or you have some sort of blood problem that makes your blood thick. These clots can travel up to the lungs, and these are the kind of procedures that we would do. Again, we would put in a filter basket temporarily sometimes if we need to. Most of the time for blood clots, we just put people on blood thinners because they don't need a filter. If the filter needs to be removed, we can use it. We can do all of this minimally invasively with wires and catheters. But if the filter has been left in for too long and something dangerous were to happen, like for example, a filter is now perforating, let's just draw a little piece of intestine here, a little piece of your intestine. There's a little filter strut perforating the intestine. Well, the surgeons are the ones who can open you up, surgically open the belly, and move the intestines out of the way, identify the main vein, and open up the open up the vein, and remove that metallic filter out of the actual abdomen, and then close up the vein. And with the help of a general surgeon, or even sometimes by ourselves, we can repair the problem with the intestines. So again, I'm just trying to explain to you how arteries, veins, minimally invasive open surgery, it all ties in with what we do as vascular surgeons. And anywhere in the body, essentially, that is relevant to the blood vessels, there can be some sort of disease. I mean, at this point, I think I've operated on almost every single body part throughout my short career so far, and I'm expecting to go quite a bit longer. So I will get to see it all in time. So let me just change my color back, and I'm gonna just go back up here. We're going up towards the heart with our IVC. Here's the heart back here again, and it empties in like this, but then there's also blood coming down from the brain, from across from the left. I'm not a good artist here. I'll do better pictures on the next drawing. But you can have issues like over here where we could put in, let's say this is the jugular vein. This is from the left hand, left arm. Blood is going back this way. You can have problems like this is the area where, as a vascular surgeon, we would operate and do things like catheter placement. If somebody needed to get hemodialysis, we would do things like a port. If you need to have chemotherapy, we can do things like there's some people who have compression of these veins by a rib. I'm going to draw a rib as gray here. Here's a clavicle. And here's your rib. And you can imagine that if the vein is traveling in between these two, you can end up with compression of the actual vein in between the clavicle and the rib. And in these cases, we may need to cut the rib out and actually open up the space to fix things like thoracic outlet syndrome. So patients have compression syndromes throughout their body in the veins. They have such as Mayferner syndrome, which is a compression of the left leg veins and makes people have left leg swelling. Even if you don't have a DVT, if you just have a big swollen left leg, that could be a compression syndrome. Vascular surgeons can help with that. Nutcracker syndrome, pelvic congestion syndrome. There are a number of different compression syndromes. Popliteal entrapment syndrome, both in arteries as well as in vein on the vein side. And I guess I should go along with that with the veins. We do even smaller procedures like PICC line placements. We help people get access if patients have difficult veins and have been stuck numerous times over their career. And so at the end of the day, it doesn't really matter where you are in the body. The point is that as a vascular surgeon, we're here to help you. What else can we talk about regarding vascular disease? So when you talk about vascular disease, there's no way to discuss what vascular surgeons do without basically clarifying that there's two sets of patients who should be aware of the fact that they need to be potentially, there are two sets of patients who need to be aware of the fact that if they have one of these two conditions throughout their lifetime for a long period of time at a high degree, it probably is likely that you will have some vascular disease and you may need to see a vascular surgeon at some point. So if you are a smoker, and when I say not somebody who smoked 100 cigarettes in their entire lifetime, or smoked some marijuana on and off, but if you are somebody who smokes, and I mean chronically smokes, who start, you know these people who start at 7 years old. If I was somebody who started at 15, 12, 20 years old, I'm now 70 years old. I've been smoking a pack a day for 50 years, 20 years, 30 years, even 10 years, depending on who you are. It can significantly change the hardness of the blood vessels, and you can build up something called plaque within the blood vessels. And the other set of people who should be aware of this is diabetics. I find that of all of the two things, if I had to ask two questions of people when they come into the office and I'm worried about vascular disease, I ask them if they're diabetic. And when I ask them diabetic, I talk about insulin years. I say, how many years have you been on insulin? That's like the same thing as saying, how many years have you been smoking the cigarette? My explanation to patients when they come in to see me is that we are all living life as if we're driving in a car. We're driving towards a cliff edge. Whether you press the gas pedal or the brake pedal is up to you. I'm not here to judge. I'm just here to help guide you and give you the best advice so that you can enjoy your life and what time we have on this earth. So with that said, if you smoke, you're pressing the gas pedal towards the cliff edge. And if you are diabetic and you're poorly controlled on insulin, you're on the gas pedal also. If you control your diabetes very well and are very rigid about it, and you eat a healthy diet, fruits and vegetables, etc., and you control your blood pressure and do all the other things that you know are good for you, I promise you that you are on the brake pedal at that point. So diet, fruits and vegetables, no meat. Just get rid of the meat altogether. I love meat. I eat steak all day, but I know that meat is not good for me. But it doesn't matter. I enjoy eating meat, so I sometimes I press the gas pedal, and it's what it is. But I would say that as someone giving you medical advice, totally unbiased, not related to the food industry in any way, I think that the healthiest foods you can eat are the ones that are organically sourced and possibly even homegrown, and if you have that ability, and then the ones that are plants. The things that are plant-based, if you can get your protein from nuts and beans, that would be better in my opinion than getting your protein from a cow or a chicken, even if the chicken or the cow is farm fresh raised, cage free, blah 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 blah, organic. It does not matter to me. At the end of the day, there's a certain vertical integration of all of the toxins and everything else that's out there, from the rainwater all the way back, and it all accumulates at the highest level of the food chain, which usually is an animal. So when you start eating animal products, you're automatically exposing yourself to highly concentrated versions of whatever is in that food source. So diabetics and smokers, vascular disease, you might need to see a vascular surgeon at some point, and you might need to come and see us for one of the many things that we do. If you have blockages in the legs, and I'll talk about, or blockages in the arteries, let's just talk about blockages in the arteries for a second. So let's go back to the red side, and don't forget to remind me to talk about lymphatics too. But let's go back to the red side of things. Blockages in the arteries. If you have a heart with a coronary blockage, here's the little blood vessel that feeds the muscle, and the blockage is here, that can cause a heart attack because this area of the heart could die, the muscle here could die when this becomes blocked, right? So the blood flow that should be going this direction can't get there because of a blockage, and this area of the heart muscle dies, and that's what's called a heart attack. If you had leg vessel pain, and the blood flow is supposed to be going down to your right leg and your left leg, and you have a blockage all of a sudden here, I'm putting it here in black, then you can imagine that this person's right leg, in the worst case scenario, if the whole thing blocks, you could lose your entire leg. But in what more likely happens in reality is that people develop these blockages over time, and they develop alternative pathways to bring the blood down, which are not as efficient, but they to some degree work, and they bring blood down around the blocked areas. And so what people end up having is, this would be the iliac, and this would be a femoral. This is at the groin level. But if you imagine you have a blockage up in your pelvis, up here in your up what we call the iliac area, then the person's entire right leg would be in pain, and that ends up with a situation with people having pain in their buttocks when they walk because they have big buttock muscle, and that the gluteus maximus and medius and minimus does a lot of the work for us. The hip muscles and thigh muscles have burning pain and tenderness, especially when you're doing a lot of work and exertion, because it's just a matter of supply and demand. Lots of muscles needs lots of energy, and if the oxygen is bringing the energy to these muscles, and you're walking a lot, and then you're going to have cramping in those areas. And in the worst case scenario, it's much worse than cramping. It becomes total death of the tissue. And so gangrene is the very end result of very severe lack of blood flow. But I would say that way before that becomes pain when you're doing nothing whatsoever, and even before that you have pain when you just start to walk a bit. And so vascular surgeons, are very instrumental when it comes to the lower extremities and peripheral arterial disease, and we'll do a whole separate lecture on that with some case examples as we go along. And if you have questions about any of this, just ask me in the comments, and I can give you an update. But when it comes to the lower extremities, we will put stents in, we will do bypass surgeries. This is where a vascular surgeon will be able to help you. If, let's say you went to a cardiologist or some other interventionalist, they tried to put a wire up and stent this, which is totally possible. Sometimes you can get a wire up and you can stent it, right? Let's put a stent. Let's make the stent in a different color. Let's make it gray. So here we have a successful stent placed. Erase this. Now you have a successful stent placed here. Now in this case, the stent is in the actual blood vessel and it's working. But let's just say you continue to smoke and you continue to have diabetes, you continue to get older, and the disease comes back, and ultimately the whole stent goes down. They try to do it again, they can't get across it, it doesn't work. Now you come to a vascular surgeon, and a vascular surgeon can do a number of different things for you. Your vascular surgeon, I'll put the different options, let's do some different options here. Might be able to take a graft, put this yellow graft in, and go from above the blockage by opening your belly, and then opening your groin and sewing a graft in above and below. That's one option. This would be an aorto femoral femoral from aorta. So aortofemoral bypass graft. And that would work if you're a younger person or if you're healthy enough to undergo it. Even older people, if they're in relatively good shape, they can tolerate an opening the belly and sewing a graft in. And typically what I find is that the bigger these operations are, the more durable these operations usually are. So what has happened over the years is that we have societies like the Society of Vascular Surgery, and they regulate. They don't allow us to just do big open surgeries just to experiment. You have to show that what you're about to do is going to have a benefit that's going to be worthwhile for the risk that you're about to let this patient undertake. So typically, if you think about it, the bigger the operation, you're going to get a better result usually, but at a higher cost in terms of your surgical, kind of risk, as you would say. And that's just a typical. It's not always the case, but I want to keep that in mind for you. The alternative to this you could do if you had a situation where your left leg was open, and we can do this one. Let's do this one in blue. Is we could do what's called, we could take blood from the left femoral to the right femoral and do a cross femoral bypass. So let's say you weren't healthy enough to have the yellow operation. We're going to do a cross femoral bypass graft, and we tunnel this right underneath the skin of your abdominal wall, like so. Right where your bladder is and your pubic bone is, we just go right underneath that skin and bring that graft right across. And to be honest, we go lower than the skin, we go deeper than there's skin, subcutaneous tissue, there's fascia. We go above the anterior abdominal wall fascia, but below the subcutaneous tissue, and usually that's enough protection for the graft so it doesn't get infected. But these operations do come with risks of infections and the size of the surgery, etc. And then there's even options like bringing blood from an arm vessel. We can put this one in green. We can come from the arm vessel all the way up north. Imagine here's the heart. Let's rub this out. Right? And here's an arm vessel going off to the right arm. Now we take because we don't want to do an incision, or let's say the blood vessel over here is blocked, and we can't get blood flow from either option here. Now we come from the right arm with our graft from the axilla. We come from the axilla and bring it down to the femoral. But you can see the problem already with this. This is a very long graft. This is coming all the way from the arm, right underneath the clavicle, and going all the way down, right underneath your collarbone, and going all the way down to your groin. So you're talking about something that's very, very long, and it's much harder for that to stay open. The longer a graft is, the longer a stent is, the more that we do to you as a patient, the less likely it is to succeed long term. The shorter it is, the better it is. The bigger it is, usually the better it is. The smaller it is in terms of diameter and size of the tube that we've done or created or operated on, the less likely it is to work long term. So these are just some of the considerations when you think about vascular surgery and peripheral arterial disease. What else do we take care of in the arteries? So we talked about peripheral arterial disease, we talked about the abdominal aorta. I'm going to show you guys a video of an abdominal aortic aneurysm that we repaired this week with an open operation, and just give you a sense of what it's like. And other than that, I think we should talk about carotid disease and carotid plaque buildup at some point. We should talk about gangrene of the legs, diabetics, amputations, the fact that many times it's actually the vascular surgeons who have to do anything from, if you have someone's foot, let's draw this here. Let's see if I can find some space on the board here. So we'll do a person's leg here in kind of a gray. Here's the femur. Here's your hip bone. Come down like this. That's my best example of a femur. And then you will have the tibia. We're doing the left leg here. And the smaller bone, which is the fibula. I'm going to erase this. So here's the fibula. The tibia comes down like this and becomes a calcaneus and tibio-talar joint. And then you have the bones of the foot down below. You have long bones, you have a few cuboidal bones. You can draw this in more detail later. And then you have the toes. So vascular surgeons are sometimes doing toe amputations, partial toe amputations, and we will help guide you with a partial toe amputation. Sometimes they have gangrene that's across 2 toes, and we have to take 3 toes and leave 2 toes on. Sometimes we end up doing a transmetatarsal amputation, cutting across all of these, a TMA, where you have no more toes, but you actually have a foot that's shaped something like this, and you can put it in a shoe with your laces, and we put a spacer in the front. We can get you fitted with an orthotic so you can continue to walk with a TMA, transmetatarsal, right across this bone, these bones are called metatarsals. And those are the bones that connect and kind of move the toe digits. So the metatarsals, the corollary in the hand would be right about here. So then we'll do a transmetatarsal. We could do multiple other operations, Lisfranc, Chopart amputations. Those are more rare, but these are all just different amputations, deciding on which level. Symes amputations, and then below knee amputations, and high below knee amputations, and then through knee amputations, and above knee amputations. And even I have never done this, but I have a colleague here who helped me out once with a patient who was not doing well, and he actually did for me a hip disarticulation. I was never trained to do that, so I would not do it, but I would usually find someone else, either another vascular surgeon who feels comfortable doing it, or an orthopedic surgeon to do that. So you have a lot of different operations that don't seem to be related to the vascular system. These are all surgeries related to more bones and more like an orthopedic procedure. And orthopedic surgeons certainly do these operations day in, day out across the country. And I would say if you have an orthopedic surgeon who can do this for you, then that's great, and that's fine. But many times the vascular surgeons are the ones doing it. I think we should talk briefly about veins and lymphatics. So just giving you a concept of veins and lymphatics. The veins in the body, I'm going to draw a vein here. Here's your IVC, femoral vein, iliac vein. And this is now the external iliac vein and femoral vein. Here's a superficial little vein. Little superficial vein. We call this vein the great saphenous vein. This is the bigger vein. This is the femoral vein. Sometimes there are 2 paired femoral veins. I'm just going to draw one for this purpose. You get lower down behind the knee. We'll call it a popliteal. And then typically this is coming from multiple little veins. And they're all joining up to make here's the foot. Excellent looking foot right there. These are the veins coming this way. And these veins are all draining this direction. So you can imagine that if you are draining up, if you're pushing blood up your leg, the problem with vein disease is that gravity is in this direction. Which means that if you have a column of fluid standing in a blood vessel, in a tube, just like in a straw, the pressure is higher at the bottom on the inside of the vessel, and it's lower at the top. If you think about that in a conceptual way, if you have a straw filled with fluid and you open the bottom, it's all just going to roll out. If you have a long balloon, those kids' balloons that we play with, that they blow up and make into animals, and you fill it up with fluid, and you turn it up like this, the bottom just goes and just blows out, because the pressure is so much higher at the base. And ultimately what it means is that if you imagine your veins of your body to be like a balloon like that, then it means that the reason why your legs are swelling at the end of the day typically is because the pressure is greater. And the reason why a woman has swelling at the end of the 9th month of pregnancy and at the 8th or 9th month is because that baby is compressing the vein up in the pelvis and then increasing the pressure all the way up. So here's your baby, and the baby's sitting right on top of this vein, right, and compressing this vein. Similarly, a fibroid tumor, ovarian cancer, or any sort of intrapelvic problem can cause you to have leg swelling like that. And this is what people need to realize, that it doesn't have to be a compression from the inside of the vein or a blockage on the inside. It could be something compressing the vein from the outside. Remember, these veins are not high pressure systems being pumped like the heart, like the arteries. The veins are a low pressure system just passively kind of percolating fluid back up towards the heart. One of the things that we should mention about the veins briefly, I try to explain this to my patients in clinic, is that the veins have, and just bear with me guys because I'm not rehearsing any of this, I'm just going off the cuff here. The veins have one-way valves. And let me change the size of this. Here are the one-way valves, right? Throughout the veins of your leg, you have these little one-way valves here. And how these one-way valves work is that they keep the blood going upward, so that whenever the blood goes up, it passes through the vein, and when it tries to turn around and go down, it hits the valves, and the valves go from being open like that. As the blood goes down and hits them, the valves close, and the blood cannot go down any further. So it's sort of like you built a ceiling. You've separated each segment every 10 centimeters or so. You've separated up the vein into different compartmental pressure, so the pressure is not transmitted all the way through and through. And that allows us to work long term over the next 80 years of our lifespan. Sometimes it doesn't work. Sometimes the veins get damaged from blood clots, inflammation, trauma, whatever it may be, standing around, genetics. It could happen for a number of different reasons. But the point is that if this happens, then you end up with leg swelling, usually because the blood is pooling and going down back into the leg. In fact, what I tried to explain, something I explained to one of the patients today, was every single thing that happens in your body, if you have a leg that's swollen and you have any valves that are not working in that leg, for the rest of your life, whenever you have any medical problem, you end up in the hospital with COVID, you end up with a burn, you had a traumatic car accident and they had to put IVs in place, and you were injured in some way, even something as small as just having a pneumonia or something not related to your legs will swell up, because we will pump you up with IV fluids to keep your blood vessels filled with fluid. As those blood vessels become very leaky, while you're in the sick phase and trying to recover, and ultimately what will mean is that the legs will get swollen. So I tell people with vein problems, you should be wearing some sort of compression garment to squeeze the legs together. You should be elevating that leg when you're in the bed in the hospital, and anytime you go to the hospital, you should be taking that extremely seriously. I mean, the nurses and team all works towards that end, but it's not just our responsibility. It is partially your responsibility to make sure you're elevating that leg in the bed, to make sure you have the right compression garments on. You know how bad the leg swelling has been in the past. You want to at least try to make sure this does not happen again, because every time the leg gets swollen, it causes more damage and more inflammation to the vein, the fat tissues around your veins, beneath your skin. It damages the skin. It's just a never-ending cycle of constant repetitive damage, and we want to avoid that. So when it comes to vein disease and vascular surgery, we treat varicose veins, which basically, in the case of varicose veins, the superficial, in the case of a leg, you have two different vein segments. Here's the bone. Here's the skin. I should say, this is the skin. This is the fascia. And here's your, your subcutaneous fat is in this area here. Well, everybody's leg is sort of the same like this. This fascial layer here is what, this fascial layer here is what separates the fat and subcutaneous tissue from the actual kind of major important organs, right? So if you want to know where the vein is, the vein is running, there's two sets of veins. Let me make that a little brighter purple. Here's a vein, superficial vein, and it's running all the way up from the foot. So imagine we're looking at it 3D. It could be running up like this, all the way up through this layer. Here's the person's foot down here, far away. We're looking from a top-down approach, and blood is going up this way and going up towards us. And then there's deep veins, which are much bigger usually. I'm gonna draw this a little bit better for us. Here's the bone, and we're going to draw in some muscles, bundles of muscles. I'm not drawing anything specific here, I'm just kind of showing you how the leg is typically made up. And I'm going to draw in now an artery. Here's the artery, and then here's a big vein next to it. And these veins over here, and then usually there's a big nerve right here too, right? So you have the deep. This is the difference between the deep and superficial systems. When you're looking at the deep and superficial systems, the superficial systems are the ones that we can usually take those veins out underneath the skin, the ones that are just underneath the skin, and take them and do a bypass surgery on the heart. A heart surgeon will take it into a bypass surgery on the heart. Many people will, family practitioners, cardiologists, vascular surgeons, interventionalists, everyone and anyone is trying to ablate these veins and treat varicose veins. Dermatologists, I mean, the amount of people treating varicose veins is pretty incredible. But the point is that these veins are somewhat expendable, somewhat. For the most part, if you don't actually need them, you can remove them, strip them, burn them, glue them, laser them, whatever you want to do, inject them with sclerosants and try to get rid of them, because if they're not working and all of the valves are actually allowing blood to go down, sometimes they're actually causing you more trouble than what they're actually worth. You cannot do the same with the deep veins. Right now, as we stand in 2024, our technology is just not there. We just don't have the capacity and the technology yet to do really reliable, robust operations that actually work on the deep veins. And there's a lot of research going on, and it's been going on for years around this, but as of right now, I don't know of any specific hospital that's doing a lot of deep vein valvular reconstruction that is widespread and available to the 7 billion people who are out there living in the world, with 20 to 40% of us having some degree of vein insufficiency. So and you're going to hear somebody say, well, we do X amount of valve reconstructions. Well, I live in Syracuse, New York. I live in Springfield, Mass. I operate in the northeast of America. I don't see a lot of that. I mean, that's just, and these are pretty populated parts of the globe. And if I don't see it where I'm at in large amounts, it's probably not that common everywhere else. So everything in perspective, guys. We have to talk like we're real people, not like we're just scientists. Patients are out there, they're looking for help and they're looking for answers. And our job here is to educate them on the realities of life, not just the book answers about what it could be. So I think I'm going to leave it at that for now in terms of vascular surgeons and what we do. I could certainly talk a lot longer, but I want to stop here. And if you guys have questions or comments, please don't forget to leave them in the comments. Critique my drawing ability, critique anything you want to do. I will do better next time. This is my second time using this pencil and drawing system, and maybe what I'll do in the future is draw the pictures first and then come back to you guys, or maybe I'll come back to some of these old pictures as we do some new stuff. So the next video I'm going to do, hopefully today or this afternoon, is just a short video on Instagram explaining about a case we did this week. It's just kind of giving you an idea of what an aortic aneurysm is, and if you want to, you can click the link below, and it should take you to the Instagram page where we'll see an aortic aneurysm, what it looks like at the end after it's repaired, and give you an idea of just what thrombus and everything looks like in real life with real pictures. All right, so thanks again for joining us, and I look forward to talking to you guys soon.